That's what I'm doing. I'm not against. I think he's doing excellent. Also with Tika.
May I add one thing regarding the dual engine cartilage after AMI or after TCI? The recent trial, just last year, 2021 published Tanush AMI trial. That trial shows that after TCI, one dual antiplatelet, one is aspirin and another is ticagrelor. The de-escalation of the ticagrelor to clopidogrel. This will continue, aspirin and clopidogrel will continue 1 month. This will reduce the ischemic rate, ischemic rate as well as reduce the bleeding risk. Tanush AMI trial.
Thank you, sir. Thank you, Professor Uddin, sir, and his team for excellent case. And thank you, Chairperson Professor Fazlur, Professor Chaudhury, Professor Ashok Gupta, and all the learned audience who participated in this session. And now we can conclude this case session. Thank you all. Thank you very much.
Thank you from on behalf of the NSCB. Thank you. একদম সিম্পল হয়েছে।
I'd like to invite Dr. Anisul Awal, sir, to moderate the next session.
Assalamu alaikum and good afternoon. I am Dr. Anisul Awal, going to moderate this session, session 5 of day 2nd. Case-based complication, how I got out of trouble. Chairpersons are Professor Nazrul Islam, Professor Sajal Krishna Banarjee, Professor A.K.M. Fazlur Rahman sir, Professor Mohammad Abdul Rahman, Professor Chaudhury Meshkat Ahmed. And the panel of experts today, Dr. Muhammad Abdul, Muqueet, Ankush Gupta, Tanush Bhatia, Arun, Maskey, and Rais Mandol. May I request Dr. Omar also, please? Would you mind being here? So this will be a very interesting session. We have very renowned speaker here, Professor Chaudhury H. Hassan, Professor Fazlur Malik, Professor Mir Jamaluddin sir, Dr. Vinita Shaha, Dr. Arun Maskey, Professor Ashok Kumar Datto, Dr. Habibur Rahman.
So I did my application talk yesterday, so I was supposed to give the high bleeding risk and PCI. So let me give you some case scenarios and then see what we can learn from this, from the cases.
Opening talk will be Professor Chaudhury H. Hassan, Catholic Director, Nevada. He is a Bangladeshi born, right now doing extremely well in US and always connected in all kinds of scientific program of Bangladesh. So welcome Professor Chaudhury H. Hassan.
So the way I look at this in terms of PCI and the challenge with the high risk bleeding, the question is, we all learn from the textbook and from the literature that we need to think about the before the procedure, during the procedure, after the procedure. And there is a huge literature now about whether we can shorten the gap and then keep on single antiplatelet therapy. But this is how I look at this. Before the procedure, we need to think about the bleeding risk. And then, for example, in GI bleed, we can assess the risk, and then we need to think and ask ourselves, should I go for the PCI? Because if I go into the PCI and cannot continue the gaps, then we have two problems. We have bleeding problem, now we have the potential of stent thrombosis and ischemic event. So let's think about that before. So I call it the thinking before the procedure, and then thinking during the procedure, and then thinking after the procedure. We know that we can prevent bleeding from non-pharmacologic and then pharmacologic way during the procedure. We talk about the access. This is no surprise that radial is better. We have gone through that. And then the femoral access, we now teach the fellows. Actually, I spend more time on teaching fellows about femoral than radial, because how you can avoid more problematic bleeding. And the two most problematic bleeding is the big hematoma and, more importantly, the retroperitoneal hematoma. We used to see this, but now fellows do not see. So I have few rules that you need to identify the puncture site, use the micropuncture needle, take a picture, and then do the procedure. Pharmacology, we talk about the dual and triple therapies, and we have gone through that. I think for this audience, I don't need to tell much. But the point is how we identify and minimize the risk of bleeding before we embark. And we need to come to a strategy, and these are all in the literature, and then I don't want to go through. Ramesh showed this yesterday, because how these discharge and then people. Let me give you some case scenarios which go to the meat of this problem. 65-year-old. I actually discussed this with Dr. Mohammad yesterday. This was his problem, not mine. So, anterior wall stent, and then hematuria in the Foley catheter. How you want to do this? So he was thinking that, it can be middle of the night, or it can be during the daytime, give lytics and then salvage and then do this PCI later. Or what do you want to do? Yeah, exactly. do the primary PCI, because which one is the predominant rule? I tell the fellows, God is not that unkind to give you two problems at the same time. But sometimes God is. So then you choose which one you take on. So any opinion from the faculty? That what do you want to do?
I will get the temperature from what? From the trauma of the formation or what's the?
What's that?
Why he has hematuria?
Hematuria, yeah. So
why? What's the reason?
So there is a Foley catheter.
A trauma. A trauma pathology.
Yeah.
So I would go to PCR.
PCI, yeah. So
in this relation, hematuria, that may be the trauma related to police catheterization. Other region, there may be thromboembolism leading to the renal infarct. That might be the region of hematuria. Such a case. So that should be kept in mind.
I think I call it a threatening situation. Which one is the threatening situation? At this point,
anyhow, if you give the latex is very much dangerous. I have experience after angiogram, her 7th grade on angiogram, after streptokinase, the patient developed a huge hematoma. So latex is more dangerous than the heparin at an even higher dose.
Yep, I think we all agree in that. Good advice we'll get from urology. So this is my bad luck. A couple of days before I left, 75-year-old with previous stents, multiple stents, motor vehicle accident, chest bruises, and then apparently he passed out also after the car hit from behind, and then was intubated, EKG, inferior stimulation, big time, 4 millimeter. So, what do you want to do? Take to the cath lab right away? So I tell that, you show me that there is no bleed. In the trauma, we have level 1 trauma. They do fast ultrasound scans. They say, you are good, all yours, the chief of trauma. And I said, okay, we'll go to the cath lab, and I shoot coronaries are normal, like all the stents painted. What do you want to do now?
Irrespectively, coronary normal. So most likely spontaneous.
Well, I tell the fellows, put a pigtail. He was actually good. He could get me a radio, which was huge. So I said, put a pigtail. It was Takasu. And I called the chief of surgery. It's all yours. 75-year-old, chest pain, troponin rising. Hemoglobin dropped to 8.1. What do you want to do now? And then we called the GI fellow. Heparin was started and stopped. And then GI fellow says, if you want us to do endoscopy, give us the clearance. Patient is having a mind. I said, who is your attending? And I called the attending and said, get the endoscopy done first. And then we'll do the angiogram. Agree with that?
Gastroenterologists differ. They don't want to do that in acute settings. They will not.
That's why I'm showing this. We need to have a good collaboration. If there is a rapid drop in hemoglobin and you are suspecting, endoscopy with the troponin rising is not prohibited for endoscopy. 70-year-old, platelet 70. This is a real case. The father-in-law of my chief fellow. And actually, so the patient is having angina. And We talked about cabbage versus PCI versus medical care. Nothing wrong in medical care. So this was the LAD on the left. I don't have that CTA. We tried to identify the problem with the CT angiogram. High calcium score, LAD. So what do you want to do?
I think I'll just go with the stamp here. If the patient's symptomatic.